Most of us don't think of heart disease until symptoms happen. By the time symptoms happen, it's too late. Traditionally, we never think of heart disease until we are in the 40s or even older. It has changed. When you're younger, you may not feel any symptoms until the blockage comes to a certain stage where it restricts the blood flow. One of the myths about heart disease is if somebody has normal or low cholesterol, they assume that they're healthy. And that's not true. The normals are defined by population studies. That may not be normal to you. The level you have is normal for the population, but not for your genetics.
Welcome to the first episode of Cardio Now, the podcast that explores the future of cardiovascular care and why it's time we stop waiting for symptoms to start taking heart health seriously. Heart disease is still the leading cause of death worldwide, and in most cases, it starts long before the first symptom. So today, we are with the man behind the mic, Dr. Mulumudi, nationally recognized interventional cardiologist and founder of Cardio Now. So I'm so excited that we're here and we're doing this and shedding light on something that's so important worldwide. And I'm so excited to be here with you. And how are you feeling your first episode? You excited?
Yeah, very excited. Thanks, Leila. I think it's an important topic that you were asking about, and this is something that needs a deeper discussion.
Absolutely.
Most of us don't think of heart disease until symptoms happen. By the time symptoms happen, it's too late because we probably did not have the opportunity to either slow the progression or prevent this from happening completely. Traditionally, we never think of heart disease until we are in the 40s or even older. It has changed. If you look at the autopsy data, meaning that autopsies done on young individuals between the ages of 15 and 34, these are young people that have no known heart disease, no diabetes, no cancer, no terminal illness. They died of some unfortunate accident or some other causes, and they had autopsies done. When you look at the arteries of those individuals, it gave us a snapshot of what is happening in young people. When does atherosclerosis really start? When does fat deposition in the heart arteries and other arteries in the body actually starts? The study was done in 1990. If you look at those, 13% of those individuals that were in those autopsy studies showed that they had advanced atherosclerosis, which is fat buildup and plaque buildup, atherosclerotic plaque buildup in the heart arteries and in the other arteries in the body. The other 87%, I said 13% had the proper fully formed atherosclerosis, and the other 87% either had fatty streak, meaning like small streaks of fat deposited along the arteries. Some of them have what is called the raised lesions. They kind of bump in the arteries, but no true blockage formation. For some reason, this 13% of the people had rapid growth, fast growth of atherosclerosis, not just being a simple fatty streak or a little bump in the artery lining. They formed a full-blown atherosclerotic plaque with inflammation. It's an eye-opening thing for us. It tells us that we need to screen people very early. We needed to identify people who are at high risk for developing this atherosclerosis and fast progression. We have the technology to look into this, which we didn't have in the past.
think that's such an important reason why we need to shed light and really rethink the way we approach heart disease even earlier. Even in my experience with much younger people, I've known people that have actually had heart attacks for a variety of reasons and suddenly passed so young. And I know that that is something that is becoming more and more common. Like you mentioned earlier, it used to be something that happened more in your 40s and 50s, and it just seems like it's happening younger and younger. And I know that you've said that heart disease starts decades before an actual heart attack. So, can you explain what's actually happening in the body at that time?
So when the atherosclerosis, we tend to use this word very often. It's basically deposition of atherosclerotic or cholesterol plaque in the heart artery lining. And this deposition of the fatty substances in the lining of the vessels, blood vessels, continues to grow. As it grows, fat creates a lot of inflammation. So the inflammatory response brings in your own cells that come and surround these fatty areas in the arteries. And those allow the blockage to grow further and eventually cause a blockage that causes the symptoms. That's the reason why when these are forming when you're younger, you may not feel any symptoms until the blockage comes to a certain stage where it restricts the blood flow and restricts the blood flow to a point where you feel it. That's when we experience the symptoms. We should not be waiting until that happens. We should probably be starting to look into things even before the atherosclerotic plaque starts happening or if it starts growing any bigger.
Absolutely. And I think you've seen some gaps in the traditional system. So, what kind of gaps, or were there any gaps that you've seen in the traditional system that really inspired you to build cardio now?
So the traditionally we think heart disease is of the middle age and elderly people. That's a very common misconception. As I was explaining to you, it starts young. And the other part of it is we relied on checking cholesterol numbers as a screening tool and as a surrogate to identify who is at risk. Is it still relevant today? Yes, cholesterol checking is relevant today. But I think if you dive deep into it, it's more involved than checking cholesterol concentration. Cholesterol has a total cholesterol number. That's the amount of cholesterol in the body, which is fractionated into LDL, low density lipoprotein, LDL. People tend to commonly call this as bad cholesterol because this seems to be the cholesterol that's most associated with atherosclerotic plaque or blockage formation. HDL, which is the high density lipoprotein, another component of the cholesterol, is typically the protective kind of a correlation. Doesn't mean the molecule protects. Maybe the molecule presence indicates that the body is properly responding to the cholesterol in the body. Triglycerides, which are kind of fatty acids floating around in the bloodstream, they tend to be fluctuating quite a bit up and down. Looking at the cholesterol concentration alone is only part of the story. We need to look at the LDL particle. LDL is the low density lipoprotein, the bad cholesterol particle sizes, particle the particle number is more important than particle concentration because concentration is a milligram per deciliter, only the amount of LDL in the bloodstream. What we're looking at particle numbers is the greater the number of particles, the greater the risk of atherosclerosis. And the other part of it is when you look at the LDL particles, you are not only counting the number of the particles, you're also looking at the particle sizes. They're measured in nanometers. They're very small particles. There are technologies to measure these particle sizes. They've been around for some time, although we don't tend to use it that often. These particle sizes, especially when they are dense and small, I tend to compare them to bullets because they're dense, small bullets. These small, dense LDL particles are the ones that enter into the cell lining and causes LDL deposition more often than larger particles of LDL that are fluffy. They're like, in my description, cotton balls. They are safe. So you want to have LDL particles to be low to start with. Even among them, you want the LDL particles to be larger, which is safer than being smaller, which are dangerous for atherosclerosis. So these type of technologies are available today for us to screen patients and to identify who is at risk of developing atherosclerosis and who are these rapid advancers, the rapid growth of atherosclerotic plaque, as I was explaining among the 13% of the autopsy individuals we talked earlier. So this is a good starting point for us to screen them appropriately with not just the LDL and cholesterol concentration, but LDL particles and particle sizes.
Absolutely. And even speaking a little bit about that, about the gaps in the system that led you to create Cardio Now, along with that, what are some of the biggest myths that people still today believe about heart disease?
One of the myths about heart disease is if somebody has high cholesterol, they correlate with having heart issues. If somebody has normal or low cholesterol, they assume that they're healthy. And that's not true. The normals are defined by population studies. That may not be normal to you. The level you have is normal for the population, but not for your genetics or your metabolism or you as a personalized care. The biggest change that I see from traditional practices and what we do at Cardio Now is We personalized healthcare. We are in healthcare 3.0. We are really looking at personalized care. We are looking at an individual as having a unique genetic makeup or metabolic makeup that allows us to look at the markers, identify the risk factors, and to treat them as needed. That is something that I see as a big gap in traditional medicine out there. I think we have come to a point where we can look at these um, nuances in the lab measurements and other indicators of metabolic syndrome or atherosclerosis or any of these. And looking at a simple lab and saying that everything is okay or not okay, I think we have gone beyond that. That is what we filled the gap at CardioNow.
Absolutely. And touching on how we spoke about how it's, something that needs to be checked earlier and earlier than before. What do you believe that heart prevention should look like for someone in their 40s or maybe even in their 30s?
My suggestion is younger patients, say less than 35, they should all get cholesterol check. They all get lipid fractionation, meaning the LDL particles, HDL particles, and particle sizes. We should do all that stuff. It's very important. That will help us identify the risk. We can stratify them as high risk or low risk individuals. That's one group. The second group of individuals aged 40 and above, my suggestion for them is to look into coronary CT angiograms. The technology of coronary CT angiograms has come to a point where we can identify atherosclerosis presence in the heart arteries because the fidelity of the imaging that we do with coronary CT angiogram today is much higher. We also have some AI tools that can analyze the plaque volume in the walls of the arteries. You can tell whether the plaque is high volume of plaque, low volume of plaque. It also tells us how is the flow across the blockage if there is any. And it also gives to some extent the plaque risk, meaning high risk or low risk plaque. The plaque is too dense, that generally means that it is lower risk. If plaque has some lucencies, think of it as liquefying in the middle of a plaque. That's not a good sign. And if you see those, we can kind of predict that the particular person is the high risk. Once we have the particle numbers and the coronary CT and to know the risk, we can be aggressive or we can target a particular molecule or particular kind of a lab with a particular medication to modify the risk. That is what we have today, which we didn't have before. This is exactly where things are moving. This is what traditional healthcare out there is not taking into consideration.
Absolutely. And speaking about that and AI tools, for example, let's talk a little bit more about tools. So, are there some exciting technologies that really allow you to detect risk earlier now than before, beyond the ones you just mentioned?
Yeah, one of the main things that I would suggest is the coronary CT angiogram has been around for some time. What came on new is it the fidelity of the images are better. They are higher quality, higher resolution, and so on. And the second part of it is AI tools to analyze the plaque volume, the plaque consistency, and the plaque presence or absence has definitely taken us to the next level of identifying and stratifying the risk for these individuals. Beyond coronary CT, beyond lipid profile and lipid checks, what are the other things that I would do is to focus on metabolic syndrome development. Metabolic syndrome is where the metabolic derangement happens in the body. It affects the every metabolically active organ in the body. That's including the heart, the brain, and the kidney, for example. So there are certain lab tests you can do. There's certain imaging studies you can do to identify the presence of any abnormalities in metabolism. Another significant thing that I would suggest is making sure that our glucose levels and glucose peaks are well controlled.
Absolutely. And what's your view specifically on personalized prevention versus guideline based care? Because from my understanding, I think that that ties into a lot of why you also developed cardio now as well.
I respect guidelines. We follow guidelines. Definitely, we should think about it. As the word defines, guideline is trying to guide you. We have to definitely look at individual nuances when applying the guideline. We should look at individual risk factors. We should look at laboratory values that are pertinent to a particular patient. We need to check. What is lacking, I believe, is we're not even checking for certain things. For example, lipoprotein A. Lipoprotein A is a genetically determined kind of LDL that is inherited. It runs in the families. It's not modified by statins, and we don't measure it around, and we should, because there are significant amount of individuals out there walking around with normal LDL but high lipoprotein A numbers. That's an independent risk factor. So we need to be looking. If we don't look at it, we don't find it.
Being that you see so many patients and now you're doing this great podcast to speak to so many people worldwide, what's one thing that you wish every single patient really understood about heart disease today?
Think of heart disease as a condition that can either be completely prevented or at least slow the progression. Don't take it as a finality. Don't think of it as something that will eventually and will happen. I've seen 90-year-olds with no plaque at all. I've seen 30-year-olds with plenty plaque in the heart arteries. Genetics play a big role in this, no question about that. But knowing one's risk, modifying one's risk can either slow it down or prevent the formation of atherosclerotic plaque in the first place. If there's one thing I can change in the population is think of getting looked at for risk of heart disease early. Even if you are not symptomatic, the detection and ability to identify the risk should start young. Because once it develops, reversal is almost not possible. Regression, there are some studies to show there is plaque regression, but it's the plaque progression we can slow down, and plaque formation is what we can potentially avoid by doing this.
Absolutely. It sounds like prevention is a practice, not just a one-time event. It's something that really has to be top of mind, especially as there's genetics involved. I think that that's also a big, crucial part of being healthy and staying on top of it and getting tested and checked to really know how your genetics may actually affect you moving forward as well. And I think that that's really the heartbeat of the show, empowering people to really step into prevention early with confidence and clarity. And in this podcast, Cardio Now, we're going to really be unpacking the science, the tools, and the strategies in every episode. So if you're ready to take control of your long term health, make sure to follow Cardio Now wherever you get your podcasts on any streaming service. And Dr. Mulumudi, thank you so much. I can't wait to dive deeper into this with you in this series and on future podcasts. So to everyone listening, we'll see you next episode. Make sure you subscribe and share. And I'll see you soon, Dr. Mulumudi.
Leila, thank you so much. Thanks for the opportunity.